I've been asked to speak on empirically supported clinical practice for problem gambling. So that will be my emphasis. However, I would like to, point out some of the emerging issues in some of the empirical literature in relation to problem gambling. So sometimes research comes out with themes. People will sort of become interested in different things at different times. And that's what I'm interested in talking to you about today, is sort of some of the things that people are starting to talk about, starting to think about in relation to clinical work for problem gambling. The aim of the study was to identify risk and protective factors for problem gambling. The emphasis was on comorbidities, which are comorbid disorders, things that go hand in hand, that are associated with problem gambling, including alcohol abuse, mental health issues like depression and things like that. In this study, we used what they call the CPGI. All right, now pay attention to that one, because that's the one that has now been recommended in most Australian states as the measure of problem gambling, if you like. Okay, it's a Canadian index. The actual index itself is quite long, but this scale that I'm talking about here is only 9 items, and it puts people into risk categories. All right, so the more you endorse, the more likely it is that you will fall into the higher level categories. Okay. In this study, we had over 2,000 respondents, adult respondents, and we were representative according to age, sex and location. So this is actually a prevalent study as well in Victoria. Basically, this problem gambling category down here is that most at-risk group. Okay, they're the ones that actually endorse enough criteria or enough items to be called problem gamblers. Down here are the non-problem gamblers, so people who didn't endorse hardly anything on that scale, right? So this is the comparison that we're looking at. Down here is what we call the relative risk. Now this is actually an odds ratio, it's a statistical analysis, you don't really need to worry about that. What you need to worry about is the number, okay? So for example, let's take divorced, okay? 78.6% of the problem gamblers were divorced, as opposed to 31.5%. Sorry? Where am I? As opposed to 6.4% of the non-problem gamblers. Okay. What that figure next to it means, that 5.6, is that problem gamblers were 5.6 times more likely to be divorced than non-problem gamblers. What we're finding here, for example, the K10 is just a measure of sort of psychological distress, and it's saying that 35.7% of the problem gamblers were in the most severe category on that measure. Okay. Compared to about 2% of the non-problem gamblers. Right? 19 times more likely to be in that category if you're a problem gambler. Right. So if we look at those, I've got it down now. If we look at those, we can see that the severe mental disorder is relevant, okay? Just psychological distress, that's all that is. Divorce is pretty big up there. Smoking is pretty big. Early big loss, you're 15 times more likely to recall an early big loss as a problem gambler as opposed to a non-problem gambler. Okay. And so on and so forth. Alcohol, we actually came out as quite impaired as a state, generally. We drink lots in Victoria, apparently. But again, 4 times more likely to have an alcohol use disorder if you're a problem gambler versus not. Okay, so key findings. Firstly, that there are high rates of all these things with problem gambling. What we need to notice is that problem gambling may be, and I probably should have put may be rather than are, okay, may be complex clients. Right? We need to know that as service providers that we're not just dealing with the gambling. Okay? We actually need to be able to coordinate care, manage clients in a way that actually allows all those comorbidities to be addressed at some level, okay, relevant for each client. It implies an integration of service delivery that we're only just at the brink of talking about. In Victoria, we have primary care partnerships, and we're talking about integrating gambling into those. Okay, so having GPs, for example, be involved in screening is important, and I'll talk about that in a little bit more in a minute. One thing I do want to mention is that in our study, the one we just did, is that half of those people who said that they wanted help hadn't actually sought it. So there's an intention there, there's a desire there, but they hadn't actually sought it. We don't know why that was, we didn't go into more detail. That goes hand in hand with estimates that we have that around 10 to 15% of problem gamblers don't actually get any formalised service provision. We hear people saying, oh no, all problem gamblers have their own problems and so therefore they're gambling to escape those problems. We hear other people saying, no, it's not about the problem gamblers themselves, it's about the product. All right? This research actually goes hand in hand with some theoretical information I'm going to present to you later on that basically said that both are true. Okay? Some people have psychological problems before they start gambling and then gambling exacerbates them, seemingly. Some people seem to gamble first and then develop some problems along the way as a result of that, which we all sort of know about that sort of gambling spiral. What these people found, oh, that's very fuzzy, sorry about that, is that almost all people who had reported problem gambling at some point in their life had another disorder sometime in their life, okay? And that figure was 96%. 64% suffered 3 or more disorders, okay? The most common ones were, and this is probably fairly typical, is mood disorders, anxiety disorders and substance use disorders. Yep. But there is a significant proportion of people down that first column that had problem gambling first. Okay, so in relation to those sort of diagnostic criteria, they're reporting that the gambling preceded the other disorders, the other problems. 74% of them, though, experienced the other disorder before the problem gambling. This is just an example of that cognitive behavioural program that I was talking to you before in relation to what we were doing. And this might give you some ideas in terms of the types of things that you would need to address if you were using cognitive behavioural therapy for problem gambling. This study was actually a comparison of controlled gambling and abstinence as a treatment goal, and I can talk to you about that a little bit more in question time if you'd like. So the first sessions focused on that and also focused on external limits of control. One of the things that I really want to talk to you about, and some of you probably have heard of this before, it's a really, really well-known and emerging model that's coming out of the problem gambling literature. It was developed by Alex Blazinski and has been picked up by Leah Nauer in relation to youth gambling, is the idea that not all gamblers are the same, which has kind of been the theme along the course of this presentation. We know that gamblers have different risk categories. We know that some people will have certain comorbidities while others won't. We found out earlier that some people have comorbidities before they gamble and vice versa. So we're obviously not looking at a discrete group of people. Okay? We're looking at a really diverse group of people who will therefore have diverse treatment needs. Alex argues that there are 3 major groups of gamblers, and the one that I think is most important is the first one. If you look at the earlier literature, there's kind of some attempts to do this stuff, the idea that not all gamblers are the same. But this one actually has a group in it that not all the others do, and that is that there are a group of normal or non-pathological gamblers. And this is the group that Gabby was talking about before, that she didn't have any major psychological issues. She had 3 life issues that were causing her some distress. Okay? And one of them became the trigger. As I said, these pathways have the implications for treatment. Okay? Alex argues that for the first group, you don't need to do all that much. Okay? Some basic counselling, some minimal interventions, some self-help, things like that will be enough to get these people to move back into just the normal gambling range. The emotionally disturbed or vulnerable gamblers, they argue that sort of CBT-like programs would be relevant for those people because of that sort of comorbid depression, anxiety and things like that. And biologically based impulsive gamblers, they argue you'd need the same kinds of skill-based interventions, but that medication might be not an alternative, an adjunct for this group as well. A couple of themes. Individuals with gambling problems are a diverse group of people with diverse treatment needs. That it is a disorder associated with other problems, but not necessarily causal to the gambling. Okay? And that we need to start screening outside of our specialist treatment services in order to enhance effective management of people within the community. Thank you very much.